To begin, I'll be introducing our first speaker, Miss Celine Talley. Celine is currently an anatomy fellow at Kansas City University and is about to begin her third year of medical school. She completed her undergraduate education at the University of Rochester with a bachelor's in general biology and later received a master's in biomedical science at KCU. In the future, she hopes to match in orthopedic surgery or sports medicine. So I'll hand it over to you.
Thank you. Can you guys hear me? All right. Hi, guys. I'm Celine Talley. I just want to start by saying thank you all for attending today. Additionally, thanks to KCU for allowing me to present my research at this year's symposium. Today, I'm going to take you all through my project, Mapping the Saphenous Nerve from Surgical Landmarks, an anatomic guide for adductor canal blocks. Now, before we get into it, I just want to answer a few questions and give a little bit of background. First, what are adductor canal blocks? Adductor canal blocks are a local anesthetic procedure that provides pain control following surgeries of the knee or leg, and it's especially popular for total knee replacements. The targeted nerve of the block is the saphenous nerve, as you guys can see here. Saphenous nerve comes off the femoral nerve, travels medially down the thigh, all the way down to the medial ankle. The saphenous nerve provides purely sensory information, which makes it ideal for nerve blocks as it spares motor function. Traditionally, this procedure is performed by an anesthesiologist with the help of an ultrasound during a preoperative or postoperative procedure. However, a 2016 study found that this procedure does not have to be only performed by anesthesiologists. Pepper's 2016 study, as well as many studies following, found that an adductor canal block could be safely performed during total knee replacements through the use of surgically relevant landmarks. In other words, by using landmarks like the medial epicondyle, tibial tuberosity, or the adductor tubercle, orthopedic surgeons could find and target the saphenous nerve perioperatively, or while the knee capsule is open. However, in reading through these studies, we discovered that descriptive data of where the saphenous nerve exists in reference to those landmarks was lacking, and finally found the goal of our study. Providing descriptive data mapping the saphenous nerve from the surgically relevant adductor tubercle. Moving into our methods. In this study, we used 18 formalin-embalmed cadavers from the KCU gift donor program, which yielded 34 lower extremities. We found and pinned the adductor tubercle using a medial parapatellar approach, then carefully dissected and traced the saphenous nerve through an incision running from the anterior superior iliac spine all the way down to the tibial tuberosity. The saphenous nerve was then pinned as it exited the vastoadductor membrane. A photo was taken of each of these pin dissections, like you see on the right, and we uploaded it to ImageJ, where we recorded the distances between the 2 points in centimeters. You can see the adductor tubercle here, and the saphenous nerve as it exits the vastoadductor membrane. The orange arrows you see are pointing to the saphenous nerve as well, which are able to be seen in this image due to the sartorius muscle being reflected. Following the dissection, we also disarticulated the femur from the acetabular joint and the patella and then we measured its length using an osteometric board in order to provide a better understanding of how these distances varied based on height. With our recorded data, we were able to create a customized code on GNU Octave, which is basically the free version of MATLAB, to produce this histogram and superimpose it on an anatomically accurate femur. Here you can see the medial condyle, the adductor tubercle, the head of the femur, as well as the greater trochanter. And just so we can take a closer look, along the x-axis here, you can see the frequency in which those ranges of distances occur, frequency which are color-coded as indicated by the color bar map. Along the y-axis, you can see 8 bins, which represent the ranges of distances we recorded of the saphenous nerve as it exits the vastoadductor membrane to the adductor tubercle here, which is indicated by the black arrow. Because of our code, we were able to represent the approximate distance of the nerve's exit from the adductor tubercle. Essentially, the distance from this black arrow to the first bin is 6 centimeters. Just a fun visual. Beyond recording ranges, we also determined our average distance of the saphenous nerve from the adductor tubercle and our femur length, and divided them into male and female categories. Overall, our average femur length was 45.86 centimeters with a standard deviation of 3.87, and our distance from adductor tubercle to the saphenous nerve was 10.33 centimeters with a standard deviation of 2.24 centimeters. When divided into male and female, the average male length was larger than the average female length for both femur length and the adductor tubercle to saphenous nerve exit, which no surprises there. In conclusion, this study illustrates the average distance between the adductor tubercle and the saphenous nerve. With this information, orthopedic surgeons are equipped with more descriptive knowledge about the spatial relationship of the nerve and the surgically relevant adductor tubercle. Some future directions I would love to take this project in is I would really like to repeat this study in order to get a larger sample size. One, to increase the power of my findings, but also to perform linear regression analysis in a larger pool. It would be great to see if there is a predictive measurement that can be used to map out the saphenous nerve in relation from the adductor tubercle. Additionally, repeating the study might allow me to record data from more female donors, where in this study there were only 6. Other future goals would include investigating the relationship of the exit of the saphenous nerve from other surgically relevant landmarks like the medial condyle of the femur, which I mentioned earlier in the study. Lastly, I would like to repeat this project using fresh frozen donors. This would provide a more realistic tissue model that is sometimes lost in stiffer formalin-embalmed cadavers. I'd like to take this time to thank my co-authors and my PI, my committee members, the KCU Gift Donor Program, as well as everyone who assisted me on this project. Lastly, thanks to you all for listening to my presentation and to KCU for allowing me to present today. Thank you, and does anyone have any questions?
Are there any questions in Kansas City?
Okay, hang on. I think we've got a question. If you have a little microphone in front of you, just press it. So nope, okay, hang on. Got it.
Hello, I was wondering if you took any other demographic information other than sex, ethnicity, anything like that?
I think I heard you ask if I took any other demographic information other than sex. Is that correct?
Correct.
And while we do have it recorded, I haven't put it into analysis at this point in this study. That is a great question.
Are there any other questions in Kansas City?
That's all from here.
Okay, awesome. Same here. Awesome. Thank you so much, Celine.
Thank you.